So in this presentation, we'll be looking at the circulatory system, particularly the heart. So we know that the cardiovascular system delivers oxygen and other sources of nutrients to the body tissue and also carries away wastes such as carbon dioxide by the blood. No? And the mechanism by which the cardiovascular system actually is able to do this job of delivering and carrying away waste from the tissues is by the action of the heart, because the heart pumps blood throughout the body and allows it to push the blood throughout the blood vessels. So the blood flow of the circulatory system requires both the pumping action of the heart and of course actual changes in the blood pressure so that there will be movement and circulation of the blood. And this is important because if the cardiovascular system cannot perform its functions, what would be the consequences? Ano ang mangyayari? Of course, we would know that waste would build up in the tissues because we know that different parts of the body, particularly its tissues, um, is highly active. It's doing its metabolic activity, and it will tend to build up waste, no, if this is not eliminated by your circulatory system. So if the body organs will not be able to eliminate waste, it will fail to function properly. And also, once oxygen is not available for the tissues, they will actually lead to the death of these tissues. Now let's focus on the heart. So we know that the heart is a muscular organ that is essential for the functioning of the body because it is able to mechanically pump blood, no, and distribute blood throughout the body. And although the heart is only a small part, a member of the cardiovascular system, which actually consists of other structures as well, including the different blood vessels, including your arteries and veins and all the different blood vessels, as well as the liquid component, which is your blood. We know that the heart is a very important member of this cardiovascular system. And we have discussed last quarter that at rest, the typical adult would actually pump about 5 liters of blood per minute. So about 5 liters of blood are pumped by the heart every minute. And for most people, this phenomenon, this activity of the heart will continue to pump approximately at that rate for more than 75 years, depending on the lifespan of that adult individual. So what we are saying here is that the cardiovascular system, if you look at it in a very simple way, is equivalent to our transport system of the body, because uh, the blood vessels, the arteries and the veins, they are like the highways in which your different nutrients and even oxygen is transported to the tissues that needs it all over the body. So the cardiovascular system is basically the equivalent of the transport system or the logistic system of the body, so that it's able to move nutrients, oxygen, and different molecules from the different parts of the body to different areas that needs this particular substance or this particular chemical or this particular compound in the body. So the heart is actually two pumps in one. So there are two pumps that are working in parallel, with the right side of the heart pumping blood to the lungs and back to the left side of the heart through the vessels of the what we call the pulmonary circulation. On the other hand, the left side of the heart pumps blood to the rest of the tissues of the body, to the systemic circulation and back to the right side of the heart through these vessels of the systemic circulation. So the heart, although it's just one organ, actually is composed of two pumps that one is on the right side of the heart circulating through the pulmonary circulation, and the other is on the left side of the heart pumping blood to the other tissues via the systemic circulation. Now, if you look at this picture, we can see here the location of the heart within the thoracic cavity or within the thorax. And see that the heart is not really big, no, it's just moderately sized and it's not even heavy. However, this actually does not reflect its incredible strength, no, and endurance. So the size of the heart, as we have mentioned previously, is that the size of a person's fist. Now, if you close your fist and you look at that closed fist, that is approximately the size of your heart. So it weighs less than 1 pound, and it is actually enclosed within the inferior mediastinum, which is the medial section of the thoracic cavity. And if you look at the picture, the heart is actually flanked on its side by the lungs. So you see here that on its side you have your lungs, no, on the left side and on the left side and on the right side. It's flanked by the lungs, and there is what we call the apex of the heart, which is directed towards the left hip, and actually it is resting on the diaphragm at approximately the level of the fifth intercostal space. So if you go on to your higher medical subjects in the clinics, if you are auscultating for the heart's sound, no, you would have to place your stethoscope and look for the heart pulsation at the apex, no, along the fifth intercostal space. Now, its broader posterior superior aspect, which is your base, actually is where your great vessels of the body will emerge, and it points towards the right shoulder and lies beneath the second rib. So this portion, the base of the heart, is below the second rib. So if you want to locate the base of the heart, you have to locate the inferior portion of the second rib, because that is where your base of the heart is. So what we have mentioned earlier is that the size of the heart is approximately the size of a fist and weighs less than 1 pound, or less than 500, 600 grams. It's located in the mediastinum, between the lungs in the thoracic cavity, and the apex of the heart is oriented towards the left side. So this is the apex. It's oriented towards the left because this is the left side. If you're facing the patient, this is the left side. It's oriented towards the left side of the person. The base is located in the posterior superior aspect below the second rib. So this is another picture. It shows to you the location of the base and the apex. So the base below the second rib, while your apex is located in the fifth intercostal space. 5, 4, 3, 2, 1. So the point of maximal intensity can usually be found at the apex, which is along the left fifth intercostal space of your thorax. So here is another diagram showing to you the location of the heart. This is the anterior and this is the posterior. So this is the patient facing forward. This is the mediastinal cavity, and you have here the heart, and it's flanked on both sides by the lungs, both the left and the right lung tissues. Now the heart is actually covered, and the walls of the heart is enclosed by a sac, which we call the pericardium. So the pericardium is the double layer sac that anchors and protects the heart. Actually, this pericardium is made up of three layers, no? Three layers. One outer fibrous layer, and so you have a fibrous pericardium, and one inner serous membrane that is actually a pair, no? An inner serous membrane that is actually paired. One is the parietal pericardium and the visceral pericardium, which is actually your uh, innermost layers of your pericardium. So the parietal pericardium is that membrane around the heart's cavity, while the visceral pericardium is the membrane actually found on the heart's surface and is equivalent to the outer wall, no, of the heart already, the visceral pericardium. Now, in between the parietal and visceral pericardium is your pericardial cavity, which is a space, no, around the heart. And this piece is filled up with your serous fluid that is produced by the parietal pericardium. So that's your pericardia that's surrounding the, the heart. So the parietal layer of the serous pericardium or the parietal pericardium is actually the one that lines the interior of the fibrous pericardium. And at the superior aspect of the heart, this superior aspect of the heart, this parietal layer attaches to the large arteries, no, leaving the heart, and then makes a U-turn and continues inferiorly over the heart surface as the viscera. So it folds, no, along so after attaching itself to the great vessels at the superior aspect of the heart, it makes a U-turn and folds along itself, no, and becomes the visceral layer of the pericardium, no, which is the one that is coating the heart already, and it is almost equivalent to the outermost layer of the heart, which is the epicardium, which is already part of the heart wall, as you see here in this figure. So in other words, the visceral pericardium is the innermost layer of the pericardium, and it is equivalent to the outermost layer of the heart. And there is between the parietal and visceral pericardium is a lubricating serous fluid produced by the pericardial membrane and collects in the pericardial cavity, and this allows the heart, no, the fluid, this serous fluid allows the heart to beat easily because it allows for the frictionless environment so that the layers of the pericardium will slide smoothly across each other during the motion of the heart. Heart wall and its covering. So this is a blow-up picture of your pericardium. So you have your fibrous pericardium, the outermost layer of the pericardium. Then you have your parietal layer of the serous pericardium. And you will notice that I have mentioned as after attaching itself to the wall of the great vessels, it will make a U-turn and then it will go around to become the visceral layer of the serous pericardium. And then it will invest, no, the outer layer of the outer wall of the heart, and it will be equivalent to the epicardium, no, of the heart wall, which is the covering of your myocardium, no, which is actually your heart tissue already. And of course, the heart wall, aside from the epicardium and myocardium, you also have your endocardium, which is the covering of the wall inside, no, the heart, no, the cavity inside the heart. So inside the heart chamber, the most superficial layer there is your endocardium already. So that is the heart wall and its covering. So as I mentioned earlier, in between the parietal pericardium and the visceral pericardium is your pericardial cavity, and there's a serous fluid within this cavity, Now, there is an event that sometimes could happen. For example, inflammation can occur in the pericardium. So there is what we call pericarditis. And this often results in a decrease in the small amount of serous fluid, no, in this cavity. And once this serous fluid will decrease in amount, this will cause the pericardial layer to rub, even to bind and stick to each other. So instead of moving friction in a very smooth manner because of the presence of the serous fluid, because there is no more, or there's a decrease in the amount of serous fluid because of the inflammation, they will, instead of moving smoothly over each other, they will stick to each other, and they will cause the formation of painful adhesion that interfere with your heart movement. And this is what you call your pericarditis condition, and that is a problem when that happens. So in general, when you look at the heart in terms of its function, there are four major functions. First, it is important to generate blood pressure by its contraction. Then it is the one that ensures the direction of the blood is in the right direction. It routes the blood. So it ensures one-way flow of the blood via its valves and different chambers of the heart. And finally, it regulates the level of blood supply via its pumping action. So when it detects low blood pressure or low blood supply, it will uh, work harder to pump in order to maintain uh, adequate blood supply to the different parts of the body. So that is the function of the heart. Now, if you look at its external anatomy, if you look at it, the surface of the heart, you will see a coronary sulcus, which extends around the heart, which separates the atria, which is the top portion of the heart, from the ventricles, which is the lower portion of the heart. So this grooves or sulci indicates the division between the right and the left ventricles as well, and it extends from in the inferior uh, portion from the coronary sulcus. You also have your anterior interventricular sulcus, which extends inferiorly from the coronary sulcus on the anterior surface of the heart. So later we will see a picture of these different grooves and sulcus. So remember, you have your coronary sulcus, and you have your different sulci, the interventricular grooves, and then you have your anterior and interventricular sulcus extending from the interior part of the coronary sulcus on the anterior surface of the heart. At the back as well, you will see your posterior interventricular sulcus. So you have your posterior interventricular sulcus, which extends inferiorly from the coronary sulcus at the back of the heart. Then you also have your blood vessels. No, you have your superior vena cava and the inferior vena cava that carries blood from the body to the right atrium. So this is where the blood that returns to the heart goes through, no, the superior vena cava and the inferior vena cava. You also have your four pulmonary veins, which carries blood from the lungs to the left atrium. So when the blood is returning, no, from the pulmonary circulation back to the heart, then it goes through the pulmonary veins. Now you also have two arteries, which are your great vessels or great arteries, which carry blood away. So you have your pulmonary trunk and you have your aorta. The pulmonary trunk arises from the right ventricle and splits into the right and left pulmonary arteries, which carries blood to the lungs, and you have your aorta, which arises from the left ventricle and carries blood to the rest of the body. So this is the surface anatomy of the heart, and these are the great blood vessels. You have your superior vena cava and your inferior vena cava carrying blood from the different parts of the body back to the heart, to the right atrium. You also have here your coronary sulcus, which is located along the line dividing the atria from the ventricle. So you have also your right coronary artery, and this is your right ventricle, and you also see at the bottom surface here your inferior vena cava. Now, on the left side, you will see here the left ventricle forming the apex of the heart, and along the surface of the right ventricle, in between the left atrium and the left ventricle, you will have your sulci or groove, no? And you will find here the different blood vessels, including the great cardiac vein, uh, which is going along the anterior ventricular sulci or groove, no? Which is the groove that separates the left ventricle from the right ventricle, and you have your great cardiac vein as well. Now these are also your other blood vessels. You have your pulmonary trunk and the aortic arch as well. So this is from the posterior view of the heart. You have the left ventricle here, you have the right ventricle, and this is the groove around the heart separating the atria from the ventricle, and you have here the great cardiac vein, and you have here the right coronary artery and the small cardiac vein, and you have the great blood vessels here. You have your aorta, superior vena cava, of course you have your left and right pulmonary arteries, and of course you have your uh, inferior vena cava here. So this is your great cardiac vein as well. At the back, you also see here your the middle cardiac vein in the posterior interventricular sulcus in the groove that separates the left ventricle from the right ventricle. And remember, this is your apex as well. So you have your four chambers of the heart. We have already discussed this, but very quickly, you have your left, right atrium, you have the left and right ventricle, and you have your coronary sulcus that separates the atria from the ventricle. Now your atrium, which is at the superior aspect of the heart, actually is considered as your holding chamber. They are not really known for their pumping action. They are more like a reservoir where the blood is pulled because they are small, thin-walled chambers. So they are not really very strong in terms of contraction. They contract, but it's minimal, just enough to push the blood into the ventricles and separating the two atrium, the left and the right atria is your interatrial septum, what separates it, the right and the left atria from each other. Now in the ventricles, you also have your walls as well. They are thicker and stronger compared to the atrial walls because they are pumping chambers. They actually contract to pump blood forcefully out of the heart and into the systemic circulation. And they are also separated into the left and right ventricles via your interventricular septum. Now, also, one thing that is we should be reminded of is that the heart, although they are separated by uh, into chambers, these chambers actually is also separated not only by walls but by valves. No, you have your atrioventricular heart valves, and there are valves between the atria and the ventricle. So your AV valves or atrioventricular heart valves are the valves that control the flow of blood from the atria and into the ventricles. So one of these valves is your tricuspid valve, and this is the atrioventricular valve between the right atrium and the right ventricle. By the name itself, tricuspid, it means that there are three cusps that is characteristic of this valve in the right side of the heart. Now, on the left side of the heart, you have your bicuspid valve, or we know it as your mitral valve. This separates the left atrium from the left ventricle, And by the name itself, we are reminded that this AV valve in a mitral or mitral valve actually has two cusps, no? Meron silang dalawang leaflets. So it's called the bicuspid valve. So each ventricle is composed of cone-shaped muscular pillars called papillary muscles. So each ventricle will contain papillary muscles, and these are muscles that are attached by strong connective tissue strings called your chordae tendineae, which are attached to the free margins of the cusp of the AV bulbs, and they function for valvular control because when the ventricles contract, the papillary muscles contract as well, and they prevent the bulb from opening into the atria by pulling on the chordae tendineae attached to the valve cusps. So in other words, your AV valves function to ensure that the flow of the blood it will be from the atria to the ventricle and not from the ventricle to the atria. No? So one-way direction lang, atria to ventricle. So hindi pwedeng from ventricle to atria. And it does that by the function of the AV valve. So here, how does it function? Let's take a look at this figure. So when the blood returns to the atria, it puts pressure against the AV valves. No, so if it's at the left, it is the bicuspid valve. If it's at the right, it's the tricuspid valve. No, so because there's more blood in the atria, it will push the valves to open. No, because of the increasing pressure within the walls of the atria, it will push the AV valves to open towards the ventricle. Now, when the blood flows into the ventricle, it will fill up the ventricular chamber, and at this time, as the ventricles are being filled up, the AV valve will hang limply into the ventricles. So it's just hanging loosely into the ventricles. Now, when the atria contract, it will force additional blood into the ventricles, no? So because of the additional pressure of the contraction of the atria, it will push the valves open because although there's blood already here within the ventricular chamber, because the pressure is greater because of the contraction of the atria. So the pressure is greater in the atria, the blood will flow into the ventricular wall because the pressure here is still building up. Now, however, when the ventricle begins to contract, so at the end of the atrial contraction, it will relax. Now, the ventricle now will contract, so there's a lot of blood in the ventricular wall. Because of the pressure inside the ventricular wall, it will force open it will force the blood to the walls, including into the walls of the AV valves. Now, the AV valves, because of the pressure, will close. So, the chordae tendineae will tighten. So, do you remember the chordae tendineae? This is attaching to the cusps of the AV valves. It will prevent the valve cusp from everting, no, like an umbrella everted to the atria. And because of this normal function of the chordae tendineae, it will maintain the closure of the cusp even though there is great pressure within the ventricular chamber. So that is how it prevents blood flow from the ventricle back to the atria because the AV valves will close, and it is helped by the chordae tendineae that allows it to resist the pressure from the ventricular contraction. On the other hand, the semilunar heart valves are actually located between the great the great vessels, no, the aorta and the pulmonary trunk and the ventricles. Now, the semilunar valves have three half-moon shaped cusps. So, meron silang tatlong cusps, and the pulmonary valve is located between the right ventricle and the pulmonary trunk. So the pulmonary valve is the one that separates the right ventricle from the pulmonary trunk, while the aortic valve is the one that separates the left ventricle from the aorta. And just like your AV valve, the atrioventricular valve, this allows the semilunar heart valves allows for the one-way flow of the blood, no, from the ventricle into the great uh, vessels, no, which are your pulmonary trunk and your aorta. And so this is how the semilunar valves function. So as the ventricles contract, so the ventricles contract and the intraventricular pressure rises because of this contraction. The blood is pushed against the semilunar valves. Now, because of the increased pressure, they will open. It will be forced to be open, and blood will flow from the ventricle into the aorta and of course also the pulmonary trunk. Now, as the ventricle relaxes, so it relaxes because all the blood are already most of the blood are forced into the great vessels. As the ventricle relaxes and the interventricular pressure falls because there's less blood in this chamber, the blood will flow back from the arteries, no, the pulmonary artery or your aorta. It will fill the semilunar bulbs and the pressure will force them to close. So they will be forced to close. However, because of the nature of the structure of the semilunar bulb, it will prevent the flow of blood from the arteries back into the ventricle. So this is how the internal anatomy of the heart will look like. So you have your right atrium, right ventricle. You have your left atrium and left ventricle. You have your AV valves. You have your tricuspid valve and mitral valve attached to the walls by your chordae tendineae. And you also have your semilunar valves here. You have your aortic semilunar valves and you have your pulmonary semilunar valves, ensuring that the blood will flow only in one direction. It will allow blood flow from the ventricles to the arteries, but it will not allow for the flow of the blood from the arteries back into the ventricle. So this is a specimen showing to you the anterior view and superior view of the heart bulbs so that you'll be able to appreciate. So here you have your bicuspid bulb or your mitral valve, and you have your chordae tendineae. At the left side of the heart, you have your tricuspid valve here, and of course you have your chordae tendineae as well. So you have your superior view, you have your aortic semilunar valve, and you have your bicuspid valve and tricuspid valve as well. And of course you have your uh, pulmonary trunk with your pulmonary semilunar valve. So once again, your heart valves function to ensure the direction of the flow is in the right direction, so that your aorta will ensure that it will not flow back. The blood will not flow back from the aorta into the left ventricle via your aortic semilunar valves, and via your bicuspid valve, it will ensure that the blood will flow from the atrium down to the ventricle, and it will not allow the flow of blood from the ventricle back to the left atrium via your bicuspid valve. No? So if the pressure increases in the ventricle, it will close the bicuspid valve so that the blood will not flow back into the left atrium. Some clinical correlation here will involve the uh, incompetence of heart valves or defective heart valves. So when the heart valves, due to any other causes like diseases or aging or atherosclerosis, sometimes the valve will not close properly. So you call that your incompetent heart valve. So that when the flow of the blood uh, is going in another direction, it is not able to close fully, and you call that incompetent heart valve. So instead of preventing the flow of the blood from the ventricles back into the atria, if your tricuspid or mitral valve is defective or incompetent, it will allow the flow back to the atrium, so there will be regurgitation, and that is a clinical problem that needs to be addressed. You also have what we call valvular stenosis, where sometimes it's due to repeated infection due to endocarditis or infection of the endocardium of the heart due to bacteria, etc. It will lead to the stiffening of the heart valve, and the valve will not open normally, and this will prevent the normal flow, no, of the blood in the direction it is supposed to flow. For example, from the ventricle to the great arteries, no, or to the arterial system. So that's due to valvular stenosis. And we have also noted that the cardiac skeleton or a plate of connective tissue actually consisting of fibrous rings surround the AV and seminal valves and give them support. And so this cardiac skeleton or connective tissue plate serves as an electrical insulation between the atria and the ventricles as well, and provides a rigid attachment site for the cardiac muscle. So this is how your cardiac skeleton will look like. So it's like a supporting structure for your semilunar valves and your bicuspid and tricuspid valves. So they are important for maintaining the integrity and the structure of your valves of the heart. So now that we know the basic structure and function of the heart, we can now take a look at the direction of blood flow in the circulatory system. So you have two sides to the circulatory system. You have your pulmonary circulation, which circulates the blood in the pulmonary tissue. Then you have your systemic circulation, which circulates the blood to the rest of the body. So when you have the venous system, which is the the blood vessels that carries blood, no, from the tissue. So you have your tissues that are metabolically active. So after they consume oxygen, um, they will give up carbon dioxide, and carbon dioxide will be absorbed by the blood and into the venous system. So the venous system is poor in oxygen because the oxygen has been taken up by the tissues, and then the tissues have given up carbon dioxide, and carbon dioxide have been absorbed into the blood circulation in the venous system. So the blood in the veins goes back to the pulmonary circulation by venous system and goes into the, if it's in the head, tissues of the head, in the superior vena cava, it's from below the head. You have your circulatory, you have your inferior vena cava system. So you have blood flowing back into the heart via your inferior and superior vena cava into the right atrium. So this is the right side of the heart, deoxygenated blood rich in carbon dioxide. Then it flows back into the right ventricle, and from the right ventricle, it is pumped by the right ventricle into the pulmonary circulation, into the lungs, where there will be exchange of gas. It will give off carbon dioxide and will take in oxygen, so that the blood will now return to the heart via your pulmonary veins, and the pulmonary veins will go back into the left atrium. So the left atrium will now the pulmonary artery will now go into the left atrium, and then you have your left ventricle pumping blood back into the aorta, then into the systemic circulation, where it will go back either to the head or into the lower part of the body, where there will be another exchange of gases, where the blood rich in oxygen will give off oxygen, and it will absorb carbon dioxide, and the blood will go back into the pulmonary circulation via the venous system. So let's just review how the blood flows through the heart. So it goes to the right atrium, then it will fill up the right atrium. Then because of the increasing pressure in the right atrium, because of the flow of blood, it will force open the tricuspid valve, and also via the pressure from the contraction of the right atrium will push the blood into the right ventricle. Then it will pull in the right ventricle, and once the right ventricle contracts, it will push the blood against the pulmonary semilunar valve, and the pulmonary semilunar valve will open, and the blood will flow into the pulmonary trunk, and in the pulmonary trunk will split into the left and right pulmonary arteries. And the left right pulmonary arteries will go into the left and right lungs respectively, and then there will be gas exchange in the pulmonary tissue, and then it will go back. The oxygen-rich blood will go into the pulmonary veins, back into the left atrium, then push against the bicuspid valve, and it will open when there's enough pressure into the left ventricle. The left ventricle will contract and will force the blood against the aortic semilunar valve, and when there's enough pressure, it will open into the aorta, and the blood will circulate to the rest of the body. So this is the schematic diagram of the flow of blood through the heart, which we have mentioned earlier already. So we know how the blood will flow from the right side of the heart into the right atrium, to the right ventricle, to the pulmonary trunk, to the left and right pulmonary artery, into the lung tissue, back by a full pulmonary vein, into the left atrium, then to the right left ventricle, then pushed into the aortic arch, and then to the rest of the systemic circulation. Now we know that the heart needs needs oxygen to work, to be able to function. So what is the blood supply to the heart? The blood supply is via your coronary arteries. So the coronary arteries supply blood to the heart wall, and they actually derive from the base of the aorta. There will be branches coming up out of the aorta, above the aortic semilunar valve, and this will supply blood to the heart wall. You also have your left coronary artery coming from your aortic arch. Then you have your three branches, and it will supply blood to the anterior heart wall and the left ventricle as well. So some of the major blood supply vessels to the heart include your right coronary artery, which originates on the right side of the aorta and supplies blood to the right ventricle. You also have your cardiac veins, which drain blood from the cardiac muscle, and they run parallel to the coronary arteries, and they mostly drain blood into the coronary sinus, and from the coronary sinus right back into the right atrium. So here are the different blood supply that you will see in the surface of the heart. You have your arterial supply here in the anterior part of the heart, and you have your venous drainage anterior surface of the heart as well. So you have your left coronary artery, which is one of the major blood vessel supplying the anterior surface of the heart, especially the left ventricle. You have also the right coronary artery, which supplies the right atrium and also a portion of the anterior surface of the heart. You also have your right marginal artery, which supplies the right ventricle, the heart. You have in the posterior portion, you have your posterior interverticular artery. You also have your left marginal artery. And of course, you have your left circumflex artery. So these are your major blood vessels supplying blood to the surface of the heart. Draining your blood from the heart will include your coronary, small cardiac vein, your posterior vein of the left ventricle, your great cardiac vein on the anterior surface of the left side of the heart, and of course they drain into the coronary sinus, draining directly into the right atrium of your heart. Now, if you look at your heart wall, the blood supply of the heart actually penetrates the surface tissues of the heart wall, including the epicardium, the myocardium as well. So you see here that there are blood supply to the outer wall of the heart, while your endocardium is supplied by some of the marginal circulation coming from the myocardium and as well as from the visceral pericardium. So the epicardium is the surface of the heart, and you have your myocardium. This is the thicker middle layer composed of cardiac muscles, and the endocardium inside the heart. You have the smooth inner surface that is exposed to the cavity, in the heart chambers. As we have discussed in a previous quarter, the cardiac muscle is characterized by a centrally located nucleus. The cardiac cell, muscle cell, is distributed uh, spindles that has a branching cell, which is rich in mitochondria. It is striated with the presence of actin and myosin as well, and it uses calcium and ATP for contraction. And one of the unique characteristics of your cardiac myocyte or cardiac cells are your intercalated discs that connect the cells so that it allows for the synchronous movement of the heart wall during contraction. Clinical correlation about blood supply of the heart, and especially to the walls of the heart, is the presence of of angina pectoris or myocardial infarction. So angina pectoris happens when, for example, the heart is beating at a very fast rate, and because of the heart rate, which is fast, maybe due to abnormal rhythm, there is not enough time for the blood for the heart to relax because of the normal rhythm of the heart. This will result to inadequate blood supply, and therefore, because of the blood supply is inadequate, it will not reach the heart tissue sufficiently, and this will result to the deprivation of oxygen of the heart tissue or the myocardium, resulting to crushing chest pain called angina pectoris. So that's why people who have heart attacks or chest pain called that angina pectoris, this is due to the loss of oxygenation to the heart because of either blockage or uh, inadequate supply of blood to the muscle tissue. And if the if the chest pain, angina pectoris, is prolonged, the lack of oxygen will lead to the death, of the cell in the muscle wall, and it will form an area called the infarct or a myocardial infarction, and it is commonly called a heart attack or a coronary acute coronary syndrome, and this will actually be an emergency because it can lead to fatality for the patient if it is not properly managed or intervened. Now, the heart also has an intrinsic conduction system that allows it to create its rhythm of contraction, and we have discussed this as well before. So you know that the pacemaker of the heart is your SE node or sinoatrial node located in the superior portion of your right atrium near the superior vena cava, and their signal uh, is propagated along the wall and reaches the atrioventricular node or EV node, which is on the lower portion of the right atrium in between the atrium and the ventricle. So it's along the walls of your atrioventricular wall, and that conduction will be passed, that signal will be passed on to the atrioventricular bundle or the bundle of His between the interventricular septum, between the left and right ventricle, and then it will branch into your left bundle branch and the right bundle branch, and then it will further um, branch into your Purkinje fibers to supply the rest of the heart wall, and this will allow the heart to receive signal from the AC node as it is passed from through the AV node down to the AV bundle, down to the bundle branches, then into the Purkinje fibers into the different parts of the heart. To review our cardiac muscle action potentials, which we have discussed as well in the previous quarter, we know that the action potentials or electrical signals in the SA node are propagated by changes in the membrane channel's permeability, and these changes in the permeability of the membrane channel will produce action potentials, which is called your pacemaker potential. and they are actually differentiated into different phases. You have your depolarization phase where your sodium channels open and your calcium channels are open, and then you have your plateau phase where there's closure of the sodium channels and some of your potassium channels will open, and then you have your calcium channels will remain open. And this will lead to the repolarization phase where your potassium channels are open and your calcium channels are also open, and this will lead to the uh, repolarization of your membrane uh, because of the changes in membrane potential. Now your plateau phase will prolong action potential by keeping calcium channels open. However, once the calcium channels open, the repolarization phase will proceed quickly. In skeletal muscle, action potential takes about 2 milliseconds, while in cardiac muscles, they take about 200 to 500 milliseconds. It's a bit more prolonged compared to your skeletal muscle action, and it has an implication because it allows the cardiac muscle to delay its response to any action potential, allowing the heart to fill up with blood before contraction. So these are the different phases of your action potential in skeletal muscle and in your cardiac muscle. So there's a different shape to the skeletal muscle action potential. Uh, so here you see that the cardiac muscle action potential is more prolonged because of the plateau phase. The plateau phase is not present in the skeletal muscle action potential, and this allows for the prolongation of your action potential. So instead of just a few milliseconds, it is prolonged to 200 to 500 milliseconds in terms of its duration compared to your skeletal muscle. So your contraction of the atria and the ventricles is coordinated by your specialized cardiac muscle cells in the heart wall, which we have already seen a little bit earlier, which forms the conduction system of the heart, including your SA node and AV node, as well as your atrioventricular bundle, the right and left bundle branches, and the Purkinje fibers. All of these cells of the conduction system can produce spontaneous action potential. However, the SA node is the one that dictates the pace of your conduction in the heart. That's why you call it the pacemaker. So the sinoatrial node, the SA node, is found in the right atrium. This is where your action potential originates, and as I mentioned earlier, functions as a pacemaker, and there's a large number of calcium channels, allowing it to prolong the action potential. On the other hand, the atrioventricular node or AV node is located in the lower portion of the right atrium. The action potential from the SA node is sent to the AV node, and then the action potential spreads slowly through it, and the slow rate of action potential conduction allows the atria to complete their contraction before action potentials are delivered to the ventricle. So it's like a gatekeeper mechanism so that it allows for uh, uh, the atrium to allow it time to contract so that it will not uh, be out of sync with the rest of the heart chamber. So from the atrioventricular node, from the AV node, action potentials will travel to the AV bundle. So the atrioventricular bundle. So the atrioventricular bundle, as we saw in the figure earlier, divides into the left and right bundle branches in the walls of the interventricular septum. The Purkinje fibers now then branch off from the left and right bundle branches, and they pass to the apex of the heart and then extend to the cardiac muscles of the ventricular walls, and the action potentials are rapidly delivered to all of the cardiac muscle of the ventricles. In summary, the action potentials of the conduction system of the heart passes from the SA node to the AV node, then to the AV bundle, then to the right and left bundle branches, and finally to the Purkinje fibers. So this is another schematic diagram showing to you the direction of the action potential traveling through the conduction system of the heart. From the SA node goes to the AB node and pass into the atrioventricular bundle, divide into the left and right bundle branch, and then they will branch out into the rest of the ventricular wall via your Purkinje fibers. One thing that you will also learn later in your higher subjects will be the use of the ECG or electrocardiogram, which records electrical events in the heart, and this is utilized to diagnose and see if there are any cardiac abnormalities not present in the patient. It uses electrodes attached to the walls of the chest, and on the paper that is read, either in the paper or on the monitor screen, it will contain waves, a bars configuration including the P wave, the QRS complex, and the T waves, which reflect different phases of the of the cardiac cycle, corresponding to the electrical signals flowing to the heart. Now, your P wave represents depolarization of the atria, while your QRS complex represents the depolarization or the contraction of the ventricles. So it contains Q wave, R wave, and S waves. And finally, your T wave represents the repolarization of the ventricles. And when you look at your electrocardiogram paper, your ECG, this is what you look for. You look for the P wave, the QRS complex, and the T wave, and changes in the normal a deviation from the normal pattern will allow you to see if there are any abnormalities in the heart. So your atrial depolarization corresponds to the contraction of your atria, and it is represented by the P wave here. So when the atria contracts, it will represented in the paper by your P wave, and then your QRS complex will represent your ventricular depolarizations. So your QRS complex, when the ventricle contracts, this will be the configuration of your QRS wave. And then finally, when your ventricles relax by a ventricular repolarization, when it relaxes, this is the shape of your ECG, and it represents your ventricular repolarization or the relaxation of the ventricles. So this is the P wave. So the duration of the P wave is measured by these boxes that you see from the beginning of the P wave to the beginning of your Q wave. You call that your PQ interval. And then the QRS complex, which represents ventricular depolarization, to the end of the T wave, you call that your QT interval. And these are important measures because they represent a deviation from this normal ranges can represent abnormalities in the conduction of the action potential in the heart, leading to abnormal rhythm of the heart. So when you look at your ECG, they actually represent as well different phases in the cardiac cycle, which is the description of all the events that occur during a single heartbeat. So we know that the heart is a two-sided pump, with the atria being the primers for the pump. It allows for passive filling of the ventricles, as well as active filling by a contraction of the atrial chamber. However, the ventricles are actually the real pumps that forces blood either into the pulmonary circulation or into the systemic circulation. So your chamber contractions of the heart will produce pressure changes, and the pressure changes are responsible for the movement of the blood from the different parts of the heart and into the different parts of the body as well, because we know that blood moves from areas of high pressure to low pressure. So these are some of the terms that you need to be familiar with in the cardiac cycle. So when you talk about atrial systole, you're talking about the contraction of the atria. When we talk about ventricular systole, we're talking about the contraction of the ventricles. Talk about atrial diastole, you're talking about relaxation of the atria. Ventricular diastole, it's the relaxation of the ventricle. So when you hear the word systole, it is contraction of the heart. It is diastole, the relaxation of the heart. So here's a summary of events in a cardiac cycle. So when there is atrial diastole, so we have the relaxation of the atria. It will allow for ventricular filling because the AV valves are open, so the ventricular valves are open while the semilunar valves are closed. So the atria will fill passively with blood, and then that will allow for, when there's contraction of the atria as well during systole, it will remain force open further the AV valve, and it will allow for the pressure to rise so that it will complete the ventricular filling, so more blood more blood will be forced out of the left of the right atria into the right ventricle to complete the ventricular filling, as well as here, in the left atrium, it will push blood down into the left ventricle. So when the ventricle starts to contract, the AV valves are closed while the semilunar valves are closed as well. So as the atria relax, the ventricles begin to contract. The blood will attempt to backflow, and this will cause the atrioventricular valves to close. No, so all the valves are closed. The AV valves will be closed because there's a attempt from the ventricle to backflow into the atria, but because of the normal closure of the AV valves, it will prevent the backflow into the atrium. Now, during ventricular systole, when there's enough pressure built up in the ventricle due to the contraction of the ventricular chamber, it will force the semilunar valves to open. It will force the semilunar valves to open, and the blood will leave the heart uh, through the aorta or through the pulmonary artery. Now, once the blood is emptied into the great arteries, it will close the semilunar valves, no? And the ventricle will start to relax. So you call this isovolumetric relaxation. Here, the AV valves are closed still because there's not enough pressure in the ventricle to, or as well as in the atrium to open. And your semilunar valves are closed as well because it prevents the backflow of the blood from the pulmonary artery or the aortic arch going back into the ventricle. So this is your cardiac cycle, no, from step 1 to step 5. This is another schematic diagram showing to you the same concepts that you have discussed earlier. Now, in your physiology textbook, you can plot. You will see figures like this where your ECG tracing can be plotted. So your waves, your P wave, QRS complex, and a T wave will be plotted against changes in volume and pressure within the chambers of the heart. And this will correspond, each of these in the cycles now will correspond to specific events, no, in the cardiac cycle. So just take a look at this figure at this time, but it's not important at your level to fully grasp everything, but it's suffice to show to you that we can actually look at different events and allow to us to compare their specific characteristic in the ECG, in terms of the pressure, in terms of the volume, and in terms of the pulsations that we hear in the heart. Now, our last topic are heart sounds, and we know that heart sounds are important because this allows us to listen to the heart activity and allows us to check if there's abnormality. So the first heart sound that we hear through the stethoscope sounds like a lub, while the second heart sounds here through the stethoscope sounds like a dup. So lub dup, lub dup. So the first heart sound is due to the closure of the atrioventricular valves, while the second heart sound is due to the closure of the semilunar valves. So when you auscultate for the heart sounds, this is how you look at it. So this is your apex. So this you auscultate here for the sounds coming from the apical impulses. This is where you have your tricuspid bulb. So when you auscultate here, you'll be hearing sounds coming from the tricuspid bulb. It is the area of your pulmonary semilunar bulb. So if you auscultate in this area, you will hear the sounds coming from your pulmonary semilunar bulb. And if you auscultate in this area, you will hear the sounds coming from the aortic semilunar valves. Now, how do you regulate the heart in terms of its stroke, in terms of the heart rate? So we know that the stroke volume of the heart, so we know that the heart actually pumps for about 5 liters of blood. So that translates to about 70 milliliters per beat of the heart. So the volume of blood pump per ventricle per contraction is called your stroke volume. And the stroke volume corresponds to about 70 ml per beat of the heart. And your heart rate normally ranges from 60 to 100. And this is the number of heartbeats in 1 minute. So typically you have about 70 beats per minute in a normal adult. Now your cardiac output is the volume of blood pumped by your ventricle in 1 minute. So I mentioned earlier that's about 5 liters per minute. So if you compute for that, it is a product of your stroke volume times the heart rate. So that is your cardiac output. Stroke volume, let's say 70 ml per beat. That's how many beats per minute. Let's say it's 100. Then you'll be able to get about 7,200 ml, about 7.2 liters. But if it's about 70, which is about the average in an adult, it will be about 490, right? So you will have about 5 liters of blood per minute in terms of your cardiac output. One of the things that you also need to be reminded of in your physiology of the heart is intrinsic regulation of the heart. So intrinsic regulation refers to the mechanism that are contained within the heart to control cardiac output. And this includes your venous return, which is the amount of blood that returns to the heart, and the preload, which is the degree of stretch of your ventricular walls at the end of diastole, or what we know as the relaxation of that particular heart chamber. So your venous return, the preload, and stroke volume are all related to each other, and in fact they are proportional to each other. And the principle that allows you to relate your stroke volume, your preload, and your cardiac output is your Starling's law of the heart, which allows you to see the relationship between the preload, or the volume that is in the heart after the end of diastole, and your stroke volume. This actually influences cardiac output. So we know that exercise, for instance, will increase venous return, will increase preload, and will also increase stroke volume, and also increase cardiac output. On the other hand, your afterload is the pressure against which your ventricles must pump blood. So if there is greater pressure, therefore it will be more difficult for the heart to pump the blood out of the ventricles. So aside from intrinsic regulation of the heart, you have your extrinsic regulation, which are mechanisms which affect the heart rate, the volume of stroke volume, and the cardiac output, either through nervous stimulation or chemical regulation. So nervous and chemical regulation are important mechanisms, including the sympathetic and parasympathetic divisions of the autonomic nervous system, to influence the activities of the heart. Now we know that both parasympathetic and sympathetic nerve fibers will innervate the SA node, and therefore will affect its activity and its rhythmicity of the heart. We have also discussed a little bit about the baroreceptor reflex in the last quarter, which is a mechanism of the nervous system to regulate heart function. So we know that there are baroreceptors monitoring blood pressure in the aorta and in the carotid arteries. That's why I mentioned to you that when you choke somebody, when you put pressure on the neck of a person, it will stimulate the baroreceptors, and this will cause changes in the blood pressure and it can cause a person to lose consciousness because the heart rate will slow down as well. So it will affect the frequency of action potentials, and it involves the activity of your medulla oblongata. So this is a schematic diagram of your baroreceptor reflex, and just take a look at it in your textbook. You also have your chemoreceptor reflex that involves chemical regulation of the heart, because your chemicals can affect heart rate and stroke volume as well. So some chemicals that leads to chemoreceptor reflex include epinephrine and norepinephrine from the adrenal medulla. This can increase the heart rate and the stroke volume. This can be due to excitement, anxiety, and anger that increases cardiac output as well. However, depression, on the other hand, can also decrease cardiac output because of the differences in the levels of your chemicals, including epinephrine and norepinephrine. Your medulla oblongata as well has chemoreceptor for changes in pH and carbon dioxide. And we know that the levels of potassium, calcium, and sodium, aside from your acidity and the level of carbon dioxide, affects your cardiac function as well. So just take a look at this chemoreceptor reflex, particularly the effect of pH on your heart rate. In summary, there's a lot of extrinsic regulation, including nervous, hormonal, and even baroreceptor reflex and chemoreceptors that allows for different areas of the body to influence the activity of the heart. Finally, in closing, in terms of clinical application, we know that one of the things that affects the heart are what you call your coronary artery disease, and this leads to a decrease in blood supply to the heart, and because of the narrowing of the coronary arteries, either due to deposition of plaques or vasoconstriction, this will lead to problems in blood supply, leading to possible myocardial infarct or heart attack, as we have discussed earlier, that lack of blood supply to the heart wall will lead to death of the cardiac myocytes, leading to infarct of the heart. Some of the things that can be considered for people who have heart blockage includes angioplasty, which is a procedure to open blocked blood vessels, the use of stent, which where you insert certain plastics or structures to keep vessels open, or you could have bypass surgery where you reroute the blood away from blocked arteries by making new connections in the blood vessels of the heart. I think that's the end of our lesson for the heart, and I hope that this will allow you to review the basic concepts in the physiology and anatomy of the heart.